Good morning, good afternoon, or good evening to all of you, wherever you are turning in from. My name is Professor Agnes Binagwaho. Thank you for joining us today to learn from our esteemed panelists about exemplar COVID-19 response from countries that have done well in preparing for and responding to the pandemic in the past year and a half. We have seen that countries that were not expected to respond effectively did so, while countries that were expected to be prepared failed to respond successfully, even if they are catch up now. This is why it's important to share experience across countries and learn from those who have done well in order to take lesson for the next health threat, because there will be other pandemics. Let me first introduce the panelists that you will be hearing from. First, we have Professor Y.Y. Theo, who is the second dean of the So Sui Ok School of Public Health at the National University of Singapore. Trained as a mathematician at Imperial College, he completed his master and his PhD at Oxford in statistical genetics. YY returned to Singapore in 2010 after working for 4 years as a lecturer in Oxford and currently a researcher at Wellcome Trust Center for Human Genetics. Prior his deanship, he was the founding director for the Center of Health Services and Policy Research and also the director for the Center of Infectious Disease Epidemiology and Research. He is presently a member of the Council of Scientists for the International Human Frontier Science Program, as well as a member of a governing board of the Regional Center for Tropical Medicine and Public Health Network in Southeast Asia. Our second speaker is Dr. Camilla Stoltenberg, who is currently the Director General of the Norwegian Institute of Public Health. She is a Norwegian medical doctor, an epidemiologist, who has served several years as both Director of the Division of Epidemiology and Deputy Director General of the Norwegian Institute of Public Health, with responsibility for strategic development of key infrastructure for research in Norway. The National Health Registry, Biobank, and population-based cohorts. The Norwegian Institute of Public Health runs most of the centralized national health registries in Norway. Large population-based cohorts, including the Norwegian mother-to-child cohort study, and a research biobank. Since the late 90s, Dr. Camilla has engaged in developing such infrastructure for research in Norway and internationally. Welcome to you both. And it's my pleasure to have you on this panel. We will have Professor YY and Dr. Camilla speak about Singapore and Norway COVID-19 response respectively. During their presentation, please feel free to post questions that we will address after the presentation. So let's start. The first slide. In my side, I will talk to you about the example of Rwanda. Can we have the first presentation? Thank you. So you can see I'm going to talk about Rwanda, and you can go to the second slide. Rwanda overall preparedness and response to COVID-19 pandemic follow what we call implementation science approach. Implementation science allow us to understand how to bridge the gap between knowledge and existing evidence-based intervention and the effective implementation. In Rwanda, we examine the challenges we face in the context, meaning there are contextual factors that are favorable and others that are barrier. For instance, we knew that we have a very low GDP per capita, and nearly 40% of our population live under the poverty line. Therefore, Any public health measure implemented would have to take that in account during the lockdown, for example. We leverage our facilitator contextual factor, such as strong leadership, a culture of accountability to implement those evidence-based, making the government, the mayors, the head of village responsible and accountable. Next slide. Next slide. So, giving our context to ensure that there is equity approach in the measure to prevent the disease, because many people will not be able to pay. All the tests, the quarantine, and the isolation for the first year were for free for everybody, so that everybody can afford to follow the guidance. If not, those who will not have been able to pay will not have done that, and all the nation will have been in danger. Next slide. We quickly adopt also or reimagine and recreate different innovation to facilitate the response. We had drone to deliver medicine. We had robot to take the temperature of the sick people because we didn't have enough personnel. And you can see also innovation in the way we do the test together, and also how we reorganize the health sector. Next slide. Next slide is about COVID vaccine. We were ready, meaning 3 months before having the first vaccine, we knew that we have to have a cold chain ready. And we know also that there will not be enough. So we ask each hospital to list the people with chronic disease. We identify all the places where people live in a crowded manner, and we vaccinate those and the health professionals. So first was health professionals, community health workers, people above 60 living in crowded situation, and all the people with underlying situation. This doesn't really stop the spread of the disease, but it avoids people to die. The vaccine landed the 3rd March and the 5th March, sorry, and the 3 days after, there were absolutely the delivery started across the country at the same time. Where there were no roads to transport them, we use helicopter for the military for the very long distance. Next slide. So you can see that overall Rwanda respect what we call effective context-informed strategy implementation with exploration, preparation, adaptation, implementation, and sustainment, because all those practices are now in our policy protocols to help us to be ready to the next pandemic with improvement of what we didn't succeed. So thank you. I think now Dr. YY and Dr. Camilla are going to do their presentation. If you can put the presentation on the screen.
Thanks very much, Professor Agnes. I believe I should be up next. So if I could request for my presentation to be put up. It's the presentation for Singapore. Could I request for my presentation, my slides to be put up?
Could we have the presentation of Dr. YY?
Anyway, while we are waiting for the slides to be put up, perhaps I can start talking about Singapore's response. And effectively, I would just send a few messages that is very specific to the use of data and innovations technology of how we have adopted those in Singapore's response. And next slide, please. Thank you. So the first thing that we did was to actually have a dashboard that could very quickly show the public what is the COVID situation in Singapore. And this dashboard provides the information on where the cases are coming from, whether they are coming from imported cases, whether they are community cases, or whether they belong to the migrant workers who are living in dormitories. And if we focus on the axis, the vertical axis, you would see that the reason why we split the migrant workers who are living in dormitories is because back about a year ago, Singapore experienced its largest outbreak where we had more than 1,000 cases per day. But all of the cases actually came from the migrant workers who are living in dormitories, and it allowed the coronavirus to spread very quickly. But with this dashboard, now anyone in Singapore or anyone in the world can actually go online to find out what is the current situation. Is it manageable or is it running in an uncontrollable manner? Next slide, please. The next part of the information that we shared with the public very transparently is actually on vaccination status. So we informed the public what is the current number of vaccines that have been administered. The baseline population number is 6 million people in Singapore. So when we see that about 2 million people have completed the 2 doses vaccination regimen, it meant that about 33 to 35% of the people have successfully been vaccinated with both doses. But overall, we could see that there were another 2.7 million people. Well, there were another 700,000 people that were in the process of receiving their doses. But more importantly, beyond the number of people that have been vaccinated, one of the biggest concerns when it comes to vaccine confidence is actually telling people what is the likelihood of suffering from a serious adverse event. And again, this is where we track those data very carefully, and at specific moments, we would actually release those data publicly. So for example, after we have vaccinated about 2.2 million doses, we actually look at the statistics and we inform the public what is the risk of someone suffering from a normal side effect, which are the expected but mild form of side effects, and what are the more serious life-threatening side effects, and how many people actually suffered from those. And we were able to present the statistics that it was a very low percentage of the people, of the number of people that have been vaccinated that suffer from adverse side effects. Next slide, please. And those information are very important to really ramp up the confidence of the public towards vaccine. Next slide, please. So the next is actually in our ability to perform contact tracing and case linkages. Because in Singapore, we actually focus quite a lot on the number of unlinked cases. And these are new cases that have emerged on a daily basis that cannot be linked with previously known cases. The reason why this is happening is because it provides a sense of how fast the outbreak is growing in Singapore, and is the situation coming under control, or is it rapidly spiraling out of control? If we start to see a lot of unlinked cases emerging from in different parts of Singapore, that's actually a very clear indication that our ability to manage the crisis has fallen behind. But if our contact tracing, our ring fencing approach is able to keep up with the case spread in Singapore, you would see that actually most of the cases that we find are from people who have been quarantined because they've been exposed, and because we test those people that have been quarantined routinely, we are picking up those infected cases. The unlinked number starts to fall on a daily basis, that's actually a sign. But one of the points of showing this particular chart is because one of the biggest outbreaks that we had in the past 2 months actually happened at our Changi airport, our main airport in Singapore. And within a matter of 10 days, we saw the spread happen across 4 generations. And that's where we realized after sequencing, we sequenced all the cases in Singapore, we saw that this outbreak was driven by the Delta variant. And that really highlighted the danger of having to cope with an outbreak driven by the Delta variant, where we could see 4 generations of spread within 10 days. Next slide, please. And the last is the use of digital technology to really track the movement and interaction patterns of people. Because for a long time, when we performed this contact tracing, we were relying on people to recall where they have been, who are the people they've been in contact with. And we could see that there are gaps, there are massive gaps in this, and if we rely on manual recall. So with a digital approach now, we are able to monitor people's interaction patterns, and we only use this, we only call out the data if someone becomes infected. That's where we will pull out the interactions data, the movement data of the individuals to start to identify who are the people who have been in contact with the case, and we are able to extend our ring fencing approach very quickly. So last slide, which will be my final slide, some lessons that we have learned so far is that the use of data actually offers very vital insights to provide very quick and agile responses to our policies. Because when we realize that we're dealing with a Delta variant, we know immediately we need to tweak our defenses to improve our public health measures. The second is really the use of data provides a very solid form of communications to boost confidence, especially during a crisis, because we are able to share very transparently with the public what is the current situation, be it about the infections or be it about measures such as the vaccine that we are rolling out to protect people. The use of digital technology also allows us to enhance our public health measures very successful. And the last point is really our ability to impose and implement these measures really has been reflective of a lot of the decision making that Singapore undertook before COVID-19 actually happened. So some of our ability to track movements were embedded in our Infectious Disease Act, which is an act governed by Parliament, where there is a control over the use of data, but the necessity during a crisis. So with that, over back to Agnes, and thank you very much for the opportunity to speak about Singapore's experience.
Thank you, Dr. Wawai, for sharing with us the Singaporean response, where you expressed that communication with the population, the trust, the contact tracing, having data, and investing in the preparedness is absolutely key for success. Dr. Camilla, I will give you the stage now to share with us the experience of Norway. Please, the floor is yours. And if we can have Dr. Camilla presentation, please.
I may start.
Yes, please.
Hello to all of you, and I may start before the presentation is on the screen. I thank you for giving me this opportunity to speak about the Norwegian response. And in fact, it has many similarities to the one in Singapore. But I've focused on other aspects of our preparedness and our response, luckily. Next picture. This is just the outline of the talk. I'll speak about Norway and the pandemic and how we have put data to use and how we've used an integrated registry in our response from day to day and how we've been following up vaccines and a few lessons for the future. Next picture. We are about 5.3 million people in Norway, and Sweden has about more than 10 million, so about twice as many people in Sweden as in Norway. And this is just a very simple comparison regarding the status of the epidemic in Norway, Sweden, and the UK. So we've had 790 total deaths associated with COVID-19 so far in Norway. And that means that we have had excess deaths below 0 in Norway. And these are quite new analyses for 2020, and the picture is similar for 2021 so far. We have vaccinated now not only 39%, these data are a few days old, and the proportion vaccinated with at least one dosage increases with between 0.75 and 1% every day. So we're now over 41%, close to 42% of the total population that has been vaccinated. And among people 65 years and older, more than 95% have received their first dosage. The uptake is extremely high, and that actually slows down the rolling out of the vaccine because so many want to be vaccinated. So we are reaching the lower ages and those without risk factors at a slower pace than we first anticipated, because we didn't imagine that we would reach above 90%, but we do. The current measures in Norway are much milder than they were earlier this year, but we have persistent, extensive testing, contact tracing, and use of isolation and quarantine. And we will continue to use that, although we will adjust it to the current situation, which is very favorable with very few people that are ill and need hospitalization. So we also have comprehensive epidemiological surveillance and border controls, and social distancing, including a limit of 20 guests in private homes, excluding those fully vaccinated. They can be there in addition to those 20 people. Next picture. Now, this is a picture to represent the 12th of March, when very strong measures were implemented within a few days. And you can see the Prime Minister and the Minister of Health, the Director of the Directorate of Health, and myself to the left. What I think this represents is that we have had a very clear political leadership throughout the whole period of the epidemic, and that has been important for the success of the response, and so has the strong and good collaboration between the Institute of Public Health and the Directorate of Health and the political leadership, the government. We've also practiced a very high degree of openness and transparency, exposing uncertainties underlying our decisions and our advice to the government, and also the unpredictability of the future of the epidemic and of deliveries of vaccines. So far, they have been more regular than we feared, but still with some irregularities and some unpredictability. There's high trust in our society, a strong economy, and high quality health care services for all, and a low population density, and world-class registry data that are collecting simple data from the whole of the public sector and from the health system. Next picture. Now, we've been putting data to use from day one, and we had prepared for that before the epidemic started. We have extensive national registries, and most important of those is the National Population Register, where we have information on all inhabitants in Norway. We also have a centralized laboratory database with information, with some clinical information, and with information from all the laboratories across the country, with immediate access both for people themselves to access their own results after testing and after vaccination when it's linked to the vaccination registry, but also where we can link it to other cohorts and biobanks and registries. For example, the Norwegian Mother, Father and Child Cohort study, where we are following with extensive data and repeated measurements and interviews people that were recruited from the late 1990s and have been followed on since then. And they include close to 300,000 people, mothers, fathers, and children. The oldest children are now more than 20 years of age. And this has been a very important source for information, for example, on how many people that have been immunized in order to assess whether we are able to capture all the cases or not in Norway, or to what extent we are capturing cases. Next picture. And in addition to these regular data sets that we have in place from before the epidemic and that we are using extensively now, we did establish a new integrated preparedness registry that was planned for before the outbreak. And that is one of the most important innovations during this pandemic, and we had planned for it and were able to establish it very rapidly using the world-class registry data that then are pre-linked and easily accessible for those of us who are responsible for the management and the response during the crisis. The registry makes possible a range of analysis and relies on high quality data from underlying registries, and we are using it every day. For example, to assess how the vaccine uptake is among people who are immigrants to Norway and have been born in other countries. Next picture. And we are also using it to link with data in the other Nordic countries, and in particular Denmark, which has very similar high quality registry data to what we have in Norway. And one important example is vaccine follow-up. So COVID vaccination is a giant experiment, and we are fortunate to have real-time, real-world data. And this combined study that you can see to the right it combines data from Denmark and Norway and provided part of the basis for the two countries to decide to drop the use of the AstraZeneca vaccine in our national vaccination programs. Next picture. This is an old study from 10 years back, and although it was published in a prestigious paper, the New England Journal of Medicine, it came out 3 years after the pandemic in 2013. And the swine flu pandemic happened in 2009, 2010. And we followed up through linkage of the data to see if vaccination was linked to fetal death. And we showed that vaccination itself was not associated with increased fetal mortality and may have reduced the risk of influenza-related fetal death during the pandemic. The good thing now is that we can do such studies within weeks or months, while we had to spend 3 years doing it 10 years back. Next picture. So lessons going forward are that we have a sort of data preparedness on at least 3 levels, and the 2 basic levels that are in place during regular times seem to be the most important one, although we add on specific data linkages in addition to those during a crisis to adjust it to that specific crisis. And science and innovation clearly has to be an integral part of public health preparedness, not only to develop vaccines, but in everything we do. High quality data is extremely valuable, and better data means more targeted response. A much stronger scientific approach for non-pharmaceutical interventions or societal interventions is needed. And our toolbox of genome-based analysis should be expanded and developed. We should build on the successes of international scientific collaboration that we've seen during the COVID-19 pandemic, with rapid sharing of knowledge and data, drug trials and vaccine development and production. And social, demographic, and cultural perspectives must be part of future preparedness against future pandemics, and we need to have relevant data to address those issues as well. Next picture. Thank you very much.
Thank you very much, Dr. Camilla. I can see, and I think all the audience will have seen, that there is a lot of similarities, as you have pointed out. even if each of our presentation have focused on different part of the preparedness and the response, you all talk about leadership, communication with the population, with trust and openness, on what we know, what we don't know, and the humility to say we need to search. The implementation of evidence-based intervention that are known from previous epidemic or previous research, data, having data, sharing data with the population in a way the population understands, so the population can contribute and do the contact tracing, and invest in tools and guidelines and protocol before the threat, meaning it's what to create a resilient health system that is capable to absorb the shock and to be adapted and flexible when the pandemic arises. Regional approach, why you have talked about the migrant workers, and you, Camilla, you have talked about bringing data together with other countries to compare, continue research, but also the resilient health system. The tools are there before, you just adapt them. So now we are going, and I just want to say that in my country, it's also the same. Trust is high. Communication is every day. The minister communicates through radio, Twitter, Facebook, and SMS. And the preparation and the resilient health system has allowed Rwanda to keep the level of primary care the same while responding to the pandemic. Dr. Camilla, the first question will be for you. Much has been said about how COVID-19 has emphasized the importance of global collaboration in data collection and research. Do you see that this increased commitment will remain after COVID-19 pandemic and its impact, because we have seen how important it is? That's the way they develop rapidly vaccine, etc. What is your view on that?
Well, my view is that we must make sure that it will continue, because although it's a great opportunity now to develop collaboration and data sharing and sharing or using the data together across countries, it doesn't happen by itself. So we have to urge that development and engage ourselves in ways of doing it and securing that it happens rapidly and that it actually makes us all better prepared for the next pandemic. But also we can use the opportunity to
Sorry, Dr. Camilla, I don't know if I'm the one who have lost you, but we didn't.
Oh, I'm so sorry.
Yeah.
I'll say it all again. I think at least we need to ensure that it does happen, because it won't happen by itself, but it is a unique opportunity that we can develop such collaborations, share data and use them in real time together. And the pandemic isn't over, so we can do that during this pandemic, but we can also be better prepared for the next one.
Thank you. Professor YY, tell me, what has been the role of universities, such as your university, in the preparedness and response against the pandemic?
Thanks very much, Professor Agnes. So actually, from the very beginning of the outbreak in January 2020, the universities in Singapore have worked directly with the government to provide inputs, whether it is on the modeling front, looking at the use of mathematical models to see how the outbreak will grow, the utilizations of PPE, the utilizations of ICU beds, of oxygen tank, such that we are able to plan resources, plan scenarios. Should we close schools? Should we open schools? Even right now, where we are talking about reopening borders, our modelers are informing the government in terms of importation risk. And we actually calculate what we call a travel risk budget. If we open up our borders to this specific country, what is the risk of importations, how many cases would we expect to see given the traffic that Singapore has with that country. All of this actually provide very helpful information to the government in making decisions. In addition to that, we constantly also perform literature reviews, systematic reviews of the literature, looking at what is the latest technology out there. Is it the use of breathalyzer techniques for screening? Is it through PCR tests or rapid antigen test? All of this information is compiled, condensed, and made accessible in a layman manner to our policymakers, such that they can be appraised of the latest scientific development out there internationally, but without having to make sense of difficult journal papers and trying to make sense of those statistics or scientific terms. And I think this remains a very important role. And it's not just the public health scientists, it is also engineers working together to put together new ways of testing. It is also the pharmaceutical sciences looking at new drug development. Even our building construction people have been roped in to advise the government on how do we develop dormitories, whether it is for students, whether it is for migrant workers, that help to be more resilient to infectious disease outbreak. And right now, because we're dealing with COVID-19, the focus a lot is on a respiratory pathogen. But you could imagine right now, we're also thinking about what would a dormitory look like that will be more resilient even to diseases such as measles, mumps, outbreaks, chickenpox. This becomes an area where having the academic input from the universities, because these are professors in architecture, in building construction, that constantly are thinking about this, bringing in the health economists to provide a sense of what is the health impact, what is the cost-benefit assessment. All of this provide very powerful information to the government to make their decision. Of course, they have to balance it with political savviness, but at least they have the evidence base generated from independent scientists to guide them. Over back to you, Agnes.
Thank you, Professor YY. And it's a general activities of all universities in Singapore?
Yes, it is. And because before COVID-19, the universities in Singapore actually already have a tradition of working together with the government. So for example, my School of Public Health, we work with the government on issues around tobacco control, around diabetes, around health promotion, physical activity. That was before COVID. So when COVID-19 happened, because there was already the trust of working together with colleagues in the Ministry of Health, that they can come to us immediately and say, oh, could we tap on you for modeling inputs for COVID-19? Could we tap on you for the evidence space? How do we understand the degree of confidence around vaccines? Over to you.
Thank you. Thank you. And I can see that you, Dr. Camilla, it was the same because you have designed those tools for data collection, data analysis before, and it's in partnership with the government because they use it in their day-to-day decision making. So another lesson is politicians just do politics and take expertise from experts, independent experts. That's a good one. So Dr. Camilla, I'm back to you. You have spoken against closure of school in Norway in response to COVID-19 pandemic. And this has also been a recommendation of WHO. Could you discuss why the recommendation was not taken up by many governments across the globe and what could have been done differently?
Well, first of all, I think everyone agrees that closure of schools and kindergartens is a very intrusive measure and has enormous negative consequences for children, for their families, for society and for the economy. So I think we all agree that one should try to avoid it if at all possible. Now, the evidence for school closures is very divergent. Some people think it's strong for closure, others think it's strong against, and you have all kinds of viewpoints between those extremes. And the evidence is not very strong. However, we knew at an early stage that COVID-19 did not affect children as seriously as it did affect older people. And we also knew that, at least in Norway, it would be possible for most children to go to school without using public transportation, etc. Although that varies in Norway also. So what we recommended from our institute was that one should have intrusive measures, and which one should have a package of those in March last year, but that one should consider not to close kindergartens and at least schools up till grade 7. That didn't happen, and I understand why, because there was a lot of fear and uncertainty about how many people that were out there without being detected with COVID-19. So we experienced a situation where the uncertainty was so big that many schools started to close on their own, and parents did not bring their children to school simply because they were too afraid. So in fact, the closure did contribute to a very strong effect immediately. Now, I think that if one should prepare better than we were all prepared when this started last spring, we should definitely prepare for keeping schools and kindergartens open, and at least for how to close them only for very short periods, and how to take care of children and schooling during those periods in an efficient and good way for children and for society. So my conclusion is that after the first period of closure in Norway, we had developed guidelines for how to keep them open, and we've managed to keep them open a lot more than comparable countries, such as some of our neighboring countries. And I think those guidelines can be used and assessed and evaluated in order to see if they can be applicable also in other countries. But the logistics and the situation that schools are in different societies means that closure may be the only solution in some places, while it isn't in others. So I think we need research and evidence that is local and that is adjusted to the actual situation that different countries are in at different times during a pandemic. So that was the long answer. But I'm afraid I have to leave because I'm going to a press conference.
Absolutely. And I'm
so
just
thank
going.
You so much for letting me be part of
Thank you, Camilla.
Excuse
Dr. YY, can I ask you a last question? We know that across the world, the vulnerable, the poor have been the most affected. How was it in Singapore, and how did you mitigate that?
So that's a very good question, because in Singapore, we did see the inequity happening as well. And of course, one area was definitely the migrant workers. Because of the way that they were living, it was clear that the risk to them was higher. And indeed, we saw that when the coronavirus entered the migrant worker dormitories, a lot of them were infected within a very short space of time. So what the government actually put in place was a series of measures to actually reduce the density within the dormitories, at the same time providing them with the financial reassurance, because a lot of these migrant workers, they were coming into Singapore to work with the intention to earn money for their family back home. And if we were to quarantine these migrant workers for a period of 14 days, 21 days, there will be lost income. But the government was very quick to come in to assure the migrant workers, to provide them with the financial support. So the financial support for the migrant workers did not come from the employers.
It came from the government, yeah.
The employers, the salary support. But in addition to the migrant workers, it was very clear also the elderly were at particularly high risk of being infected and subsequently developing severe symptoms. So the communications were very clear in the beginning that if you're of a certain age, 60 and above, if you suffer from specific comorbidities, certain chronic diseases, you're at a higher risk. Make sure that how do you take care of yourself? And that's where the communication comes in on how
Absolutely.
individuals.
Trust and communication, and mitigate the situation and also compensate for the loss of income. I think we are reaching the end of this panel. I want to thank Dr. Camilla, who had to leave, and you also, Professor YY, for the important lesson that you have shared with us, how to respond to COVID-19 pandemic effectively. It's not the first pandemic, it's not the last, and those lessons are really applicable to what other threats that can come, and learning from Rwanda, Norway, Singapore is very useful because the diversity of our country and the same application, the same evidence-based intervention, the same analysis of the context, the same way to communicate to the population, and the same way to use the leadership locally and nationally are very important in the success of those responses. Thank you to all of our speakers and also to the audience who have interacted with us today. And we hope that we have all learned something from this conversation today, and very useful, because if it works in Singapore, Norway, and in Rwanda, that means it can work everywhere. Back to you, and thank you very much.